The following podcast is part of a certified educational activity titled Navigating Rapid Changes in First and Later Line Treatment of EGFR-Mutated Non-Small Cell Lung Cancer, a practical framework for optimal biomarker testing, treatment selection and sequencing, and adverse event management. Access the entire activity and complete the post-test at peerview.com/EQU860. Downloadable slides and practice aids are also available.
I want to welcome you all to San Diego for the 2024 World Conference on Lung Cancer and our 50 years of progress at the International Association for the Study of Lung Cancer. We're so thrilled to have you all here. In this symposium, I think we're the first symposium, we're going to talk a bit about all of the great new data in patients with EGFR-mutated lung cancer. My name's Natasha Lale. I'm from the Princess Margaret Cancer Center in Toronto, Canada, and I'm really thrilled to be joined by two extraordinary speakers who are known to you all, Dr. Luis Paz-Ares, who leads the team in Madrid at the Hospital Universitario 12 de Octubre, and also Dr. Joshua Sabari, who leads his team at the NYU Langone Health Center in New York. So really thrilled to have you both with us. So today we're going to talk a bit about applying broad-based NGS testing to identify both common and uncommon EGFR mutations in patients with both advanced disease, and we'll talk a little bit about early stage. Dr. Paz-Ares is going to take us through a lot of the great new data from trials evaluating EGFR-targeted therapies in patients with common mutations, and Dr. Sabari is going to take us through the data for less common mutations, in particular EGFR exon 20 insertion mutated lung cancer. We're going to talk a little bit about the who, what, when, and why. What should you give patients first line, second line? How do you sequence? What are some of the factors that help us individualize treatment for these patients today with all these great new options? And also we'll talk a little bit about toxicity, so important while we're improving how long our patients have. We have to make sure that their quality is better as well. So I'm going to start just by talking a bit about something that you all know already, a bit about biomarker testing. And, you know, pretty much all the guidelines now recommend broad-based NGS testing, preferably comprehensive testing or some access to RNA-based sequencing for all of our patients with advanced non-squamous non-small cell lung cancer, and definitely molecular testing now emerging in early stage, especially for EGFR and ALK alterations, and to some extent PD-L1. And you know, it's been interesting. We have single gene testing. We'll talk a bit about how popular that still is even today in 2024, both here in the US and around the world. And then of course, multi-gene techniques. And to just say NGS, you know, there is a bit of buyer beware. Just because you're ordering NGS doesn't mean that you're necessarily going to get the targets that you want with the sensitivity you want. There are small panels and large panels. RNA-based testing, where you're more likely to find fusions and copy number variations. And then, of course, these days, we're moving to even bigger panels, whole exome, whole genome, and I think it's a little bit of a test of how much we clinicians can read through in any given consultation. And what's coming beyond 2024? Well, at this meeting, you're going to hear about proteomics, microbiomics, and more, and also the use of AI. Now you can even take technology, look at a digital slide, and predict, will your patient have an EGFR mutation or not, or even from their CT scan with radiomic prediction models. And so we're certainly moving forward beyond NGS, and perhaps in a couple of years, we'll even just have a breath test to diagnose EGFR. But even with NGS, and even though we all know it's what we should do, it's still not as common as it needs to be. And this is a nice study from the US oncology team. And you know, this is a really brave study. You know, there weren't very many groups in the US that were publishing what actually happened in their centers. But in 2018 to 2020, they were profiling under 40% of their patients with NGS. And by the time they got around to 2022, they've actually been able to increase this significantly, almost up to 55%. And their target for 2024 is 85%. So we're hoping to hear about their progress next year. But you can see that even here in the US, even here in San Diego, despite the availability and funding for broad panel NGS testing, a lot of patients are starting treatment without complete genotyping data, anywhere from 55% for TRAC fusions, for example, all the way up to about 80% for PD-L1 and EGFR. So still not 100% of patients starting treatment with their full molecular data. And why not? Some patients are sick too quickly, about 16% of patients with advanced disease, not enough tissue. Interestingly, perceptions and practice, a very big feature here in the US, coverage, very important, and financial barriers, and even in early stage, about a third of patients not getting any biomarker testing initiated, again, really to do with attitudes and knowledge and understanding, and to some extent, coverage. So here at the ISLC, we've updated the molecular testing survey. There was a press release earlier today, and Matt Smeltzer and the team are presenting their data tomorrow, but they surveyed over 1,700 or approximately 1,700 respondents in 90 countries from 14 disciplines. People were very aware that NGS was important, but only 2/3 of patients thought it 2/3 of practitioners thought it was essential in advanced disease, and only 30% thought it was essential in early stage disease, so not the numbers that we want. And probably about 2/3 of countries estimated that half or more of their patients do have upfront NGS access, which is better than it was a few years ago, but still not great. Big barriers: cost, time, sampling, access, and awareness, with pathologists reminding us that biomarker testing as a reflex should really be standard, and tissue availability from their perspective is the big reason why they can't help us get the job done. So to address tissue, a liquid biopsy certainly emerged as an important alternative, whether it's when tissue fails, doing both tissue and liquid NGS up front, which is now recommended by the NCCN, and so hopefully funded through a number of insurers. Plasma first, when we know things are going to be delayed, and also in treatment resistance, and we'll talk about this in some of the cases. And of course, in terms of the results, very high concordance, but often faster turnaround time. The challenge, of course, being less sensitive for complex alterations, fusions, and copy number variation. But it really does make a difference for our patients. This is a nice study from Charu Agarwal, where she showed that with the use of liquid biopsy, she quadrupled the number of patients from 20% to almost 80% that had results before starting therapy in the first-line setting. And although she's reversed the colors in her paper, those patients with results in blue had a much better outcome than patients who couldn't wait. Now, of course, some of that is bias. Patients that are sicker obviously can't wait, have to start chemotherapy, but that's still a huge difference, and it'll be interesting to see if we have any survival curves that look like that in the plenary session tomorrow and the next day. So higher rates of complete testing with tissue and plasma, greater opportunity for therapy, and less system impact in countries like Canada, and perhaps where you're from, fewer repeat biopsies and faster time to treatment. So does it matter? And this is a very nice study from, it's a retrospective study, again, completed in around 2020, where in blue, patients that were able to get their results and start targeted therapy have their survival, group A. Those that started before the results were available and then switched in red, and those that started treatment for EGFR and ALK alterations, but continued their chemotherapy even though results came back after starting treatment. And you can see that that group has the worst outcome, which really teaches us that targeted therapy as soon as possible and getting results in time is essential and matters for our patients' survival. Sequence also, when you start the wrong therapy with chemoimmunotherapy, for example, and then you want to switch to a TKI or targeted therapy, it has consequences. Fatal pneumonitis, hepatitis, and we've seen this not just with, and of course, toxic epidermal necrolysis. We've seen this not just with EGFR inhibitors, but across the gamut of small molecule inhibitors, KRAS, ALK, MET, and so on. So really important to get the sequence right. So in a world where NGS is so much better, you get complex information, you find rare variants, it is often a little more sensitive even for common alterations, and you get great data such as TP53 co-mutation or compound alterations, and Dr. Paz-Ares is going to talk a bit more about that. Why would anybody still use PCR? And the answers, of course, are it's cheaper, faster, and still to some extent, it uses much less tissue. So I think for many, including in Asia in particular, where they think they can get the answer faster, PCR is still very widely used. There are some nice data suggesting that NGS costs only a little bit more. This is a nice study from Singapore, but actually cuts down the time to treatment for patients with NGS instead of PCR. So I think, very important to start thinking about this, even in Asia, where the prevalence of EGFR mutations is so high. And I think the group that gets left out the most by PCR are those with exon 20 insertions. We're going to hear more from Dr. Sabari about these, but we do know that finding these early and starting patients on optimal therapy really is very, very important. And these are old data now from Dr. Baumel, where he showed that the common PCR kits only diagnose about half of patients with exon 20 insertions, those shown in blue, but the other half of our patients will only be diagnosed with NGS. So again, so important to do the right test at the right time. So with that, I'm just going to sum up by saying that today in 2024, complete biomarker testing is needed prior to starting first-line therapy in advanced disease, and definitely for EGFR and ALK, and we can argue about PD-L1, even for our patients with earlier stage disease, where we're going to think about a perioperative approach. Testing really matters, whether you use NGS versus PCR, whether you use RNA, which of course has greater sensitivity than DNA for all the alterations we're looking for, and understanding what you get is also important. Still so important to call people about the result that you receive. I think increasingly these data are very complex. I still get questions about what's a deletion because the reports are so much harder to understand, and you really need to know what you're looking for. Not everything is a mutation these days. We're even going to be talking about overexpression as a new biomarker for HER2 and lung cancer, and saying that a patient is biomarker positive or even EGFR positive just isn't enough anymore in 2024. We need all the data. So we do want you to tell us what you think about this case, and then Dr. Paz-Ares is going to go through some of the data for us. This is a 63-year-old lady, presents with a pleural effusion, which is shown to be malignant with adenocarcinoma. She has multiple bilateral pulmonary nodules on PET, and on testing, she's found to have an L858R mutation, PD-L1 negative, and a good performance status. And she comes to your clinic to talk about what she would do. So with that, I'm going to turn it over to Dr. Paz-Ares to take us through some of the great data in EGFR-mutated lung cancer. Dr. Paz-Ares.
Thank you, Natasha. Thank you very much indeed. So it's really a great pleasure for me to be here today and trying to review a bit of the data that we have that maybe serve us to treat next day in the clinic cases like the one just Natasha presented. So I think it's now more than 20 years since we have been using EGFR TKIs. Indeed, from the initial studies like the IPA study, the URTAC, that show first and second generation TKIs really improve the outcome of our patients. They induce more responses. They induce better PFS as compared to standard of care treatment. Next, we went to randomize for the newer generation of TKIs, third generation such as osimertinib versus first generation ERLO or gefitinib, and we really collect data that serve for the standard of care for the last 8 years or so. That is, osimertinib induced more responses and impact on PFS and overall survival. Indeed, you may expect from a patient in your clinic that giving osimertinib responses in 70% of the patients, PFS close to 20 months, and OS in the range of 3 years or even more than 3 years. And this is important because we have to move from here. We have to improve our results from here, and a couple of particular strategies had emerged in terms of data over the last few years. First strategy being trying to improve the outcome by combining third generation TKI with chemo, and the FLORA-2 study is kind of the flag study to do that. The second study would be to combine with amivantamab, with another biospecific agent which inhibit MET and EGFR, trying to get a more, let's say, comprehensive EGFR blockade. Looking at the FLORA study, patients that had not been treated before that, stage 4 patients, classical mutations, osimertinib plus chemo versus osimertinib alone. Do you remember the data? Clear improvement in PFS, hazard ratio 0.62. That means you're decreasing more than 1/3 the probability of progressing through the study. And importantly, the data may be at least as good, if not better, for those patients with brain metastasis to start as compared to those patients without brain metastasis. Hazard ratio actually a bit better for those patients with brain metastasis, particularly high-risk patients, and it's particularly good that we are having those patients with the disease control. In terms of safety, as expected, if you add 2 agents, you get the toxicity of the 2 strategies. Rash, diarrhea, so on, from osimertinib plus typical side effect of chemo, nausea, vomiting, some neutropenia, and so on. And of course, some of the side effects are actually increased. Remember, last year, Dr. Valdivieso also showed some data on the second interim analysis on OS, suggesting the data looks a bit better, hazard ratio in the range of 0.75. Still the data are not fully mature, but maybe data relevant to consider. The second strategy was trying to improve the data by using a combination of a 3rd generation plus amivantamab as compared to osimertinib alone. This is what the Mariposa trial is doing here. Remember again, classical mutations, stage 4 patient not previously treated, and they have here a 3rd arm where patients were treated with lazertinib. Lazertinib is a 3rd generation agent, likely very similar to osimertinib, as is actually being shown in this study. The main results, you're improving PFS, hazard ratio 0.7, again, you're reducing 1/3 the risk of progression all along the study period. And again, this improvement is not only happening in patients without brain metastasis, same data for those patients with brain metastasis. So you're preventing effectively those patients with brain metastasis to progress somehow. Early data in survival, may show a tendency, and indeed I invite you to go to look at some of the representation by Dr. Gadil, which is providing some updated data on some secondary endpoints of the trial with some more maturity, including time to treatment deterioration, subsequent treatment, and so on. All those outcomes are improved. I remember it looks like the data in terms of OS, not fully mature as yet, but they are improving, are suggesting that maybe is, again, as we have mentioned with the FLORA study, some benefit there. But I really like you to, or maybe suggest you to go to see the presentation. Safety. Safety is really something that we have to look very carefully here. We have to really talk to our patients also, not only the improvements in efficacy, but what are the consequences in terms of the safety profile. Here, with this dual combination, you're going to somehow increase the number of side effects related to EGFR inhibition, particularly paronychia, rash, stomatitis. You will have some side effects, particularly when you're having some months of treatment, due to the MET inhibition, particularly edema and hypoalbuminemia. And of course, you will get some other side effects. And among those, I would for sure would say some rare cases of ILD and some infusion reactions that are, of course, important with these agents. So one of the questions, and we will discuss that later, I suggest, well, we have here 3 clear opportunities: 3rd generation TKR, 3rd generation plus chemo, 3rd generation plus amivantamab. What to do? We tend to look at predictive factors. I don't think we have clear predictive factor as yet. We have some look at some obvious ones, such as commutations. We know this is prognostic. As yet, we haven't shown it is clearly predictive of the benefit from many therapies. There are some, let's say, data that are not, I would say, fully convincing to me to say that patients with commutations such as P53 are benefiting particularly from giving therapy. The data are not very robust. And in terms of efficacy, which I think is important, I'd really like to point out here some of the data from the Paloma 2 study that had given amivantamab in the first-line setting with lazertinib. If you compare the data of amivantamab Parlasi in this study as compared with using amivantamab on a subcutaneous injection as compared to the Mariposa, let's say, trial, you realize that you're getting the same data in terms of efficacy. It's a cross-trial comparison, remember that. Responses are very much the same in the range of 75–80%, and the safety profile is pretty similar with the exception of infusion reactions. Infusion reactions tend to happen in some 60–70% of the patients with amivantamab, typically during the first infusion. And of course, this is not really threatening for the patient, but is having bad time during the infusion reaction, to be honest. Not only for the patient, sometimes for the day hospital staff and so on. So it's very important to be familiarized with the management on that, but also important thing to say that you're reducing with the SciQ formulation very heavily the incidence, and we'll comment some data with another study in a minute. There are some ways to try to optimize the safety profile of the combination, and a number of studies will be presented here. I really maybe suggest you to go and to see some of the two studies. One is the skip representation, which is studying the role of particularly dexamethasone, 5 doses before starting that treatment, which seems to benefit those patients, and also the full dermatological treatment for patients that are giving amivantamab, and looks like it's also improving those patients.
Great.
My chair is going to direct that.
Thank you so much. So just returning to this case, this lady with an L858R mutation, pleural fluid, bilateral nodules, younger, good performance status. Maybe we'll start with our panelists. You know, how do you select which treatment? How do you decide? What do you use from all this data that Dr. Paz-Ares has shown? Dr. Sabari.
Difficult question. I mean, you know, we have 3 regimens now FDA approved here in the United States, and you have to discuss each one of these regimens with your patient. So I want to know what the patient's goals are. And, you know, as you said, Dr. Paz-Ares, osimertinib is a phenomenal therapy, but we need to build upon that. So I would talk to this patient about, you know, osimertinib plus chemo. I would also talk to her about amivantamab and lazertinib. And, you know, looking at some of the subset, she has an L858R mutation. It's a high-risk mutation. We don't know whether she has brain mets or not, but I might opt to use a more aggressive regimen in her, such as amivantamab and lazertinib, again, with that discussion, understanding the risks, the benefits, toxicities.
And so for your brain mets patients, do you routinely intensify, or it's case by case?
It's really case by case. I do tend to intensify by either adding pemetrexed or amivantamab to the 3rd generation EGFR TKI.
What about you, Dr. Paz-Ares?
So as I mentioned, you know, it's a bit unfortunate that today we haven't got yet really predictive factors. So, you know, we are oncologists. We tend to do also part of our guiding of therapy based on prognostic factor. That is not going to tell us which patient is benefiting, but it's telling us which patient is a particular risk because of the disease. And then I try to explain that to my patients. As Dr. Sabari mentioned, for brain metastasis is one of the situations where I somehow more inclined during my discussion of pros and cons with the patient to go. On the other hand, if my patient is really comorbid, maybe very elderly or whatever, I tend to go more TKI, and then go on a more sequential basis to some of these agents, chemo, amivantamab.
That's great. And I think there's another question from the group about uncommon mutations, but maybe before I ask you both about that, certainly in my clinic, I discuss this with patients. I think both of these studies of intensified therapy really show that all of our high-risk patients benefit from combination. You almost wish there was some ability to give induction osimertinib. We had a really good liquid biopsy test or some way to know that response is really durable and then intensify or not. But I guess more trials will have to tell us what to do in time. What about if your patient had an uncommon sensitizing mutation, 719 or an 861Q? This is all for common mutated lung cancer. What about if patients had these rare ones and they say, Dr. Sabari, would you add chemo for me? Can I have Emi-Laz? What would you say?
Yeah, I think the uncommon mutations are, an area of, high unmet need. We know that third-generation EGFR TKI are not that effective in this particular population. We're going to see a lot of data at this conference for the uncommon, now called PAC mutations, which I think are important, and we should really look at that population separately. Now, not all uncommon or atypical mutations are not responsive to third-generation EGFR TKI, so it's really important that you read on, call on your experts in your area to find out what mutations are selective or responsive to certain therapy. But for an uncommon mutation like G719 or S768, I would usually use a second-generation EGFR inhibitor, and I hope that changes in the near future with a lot of their new therapies being developed.
Sounds good. What about in Spain?
Okay, so what I tend to do is to individualize depending on the uncommon mutation. They are not all equal. There are some that are more likely to respond to second gen, as has been mentioned here, of adenib. Some others are more likely to respond to osimertinib. And then, so that is how I classically try to determine my treatment. But still remember, our emerging data, as Dr. Sabari said, the combination with laser and amivantamab, the Chrysalis-2 data are really looking really good, still phase 2 data, so, but I think it's something that you're able to access to, not my case in my country as yet. That would be an opportunity. And some of the other agents that are coming, there is one from Bayer, Chinese company, another one. A couple of agents are really good as well, looking good, so stay tuned. I think there are some new opportunities for those patients.
Sounds good, thank you, and I agree. I think there's a lot coming forward for PAC mutations and hopefully for combinations for this group. So let's say we started our lady on osimertinib, and after 12 months, she develops widespread progression in lung, liver, and bone. She remains very, very well. We do repeat biomarker testing, and only the L858R mutation shows up. No other new actionable targets or ways to streamline therapy. She comes to your clinic and wants to know what's next. So back over to Dr. Paz-Ares to take us through some of the exciting data, second line.
Okay, I don't think I'm going to review for you the mechanisms of resistance to first-generation TKI. Remember, on target, we haven't got really good therapy for patients with on-target mechanism of resistance. Off-target, we have some good treatment or reasonable treatment for some of those cases, such as, let's say, amplification of MET. And then you have some transformations, such as small cell lung cancer. You go the chemo path, let's say, and then nearly half of the patients, you don't know what is the mechanism of resistance. And this is one also part of the problem. So I would say for 3/4 of the patients, you don't have a clear treatment today, a clear personalized treatment. So some of the ways to address that is asking by using chemo, that would be the traditional treatment. If you intensify such a treatment with more EGFR blockade, are you improving the outcomes? And this is the concept underlying the Mariposa-2 trial. AMI was combined with chemo, with or without lazertinib, on those patients that have progressed to osimertinib monotherapy as a more recent treatment. You see the data, the combination of chemo plus amivantamab really improved the outcome of those patients. You really decrease by 50% the risk of progression all through the study. And the addition of lazertinib to the combination do not improve the outcome, do not really further improve the PFS. So that is something I tend not to do anymore, of course. If you look at intracranial PFS, you're also improving the outcomes here. And again, important, lazertinib is not producing any further improvement. So you do not need complete EGFR blockade. Amivantamab is enough here, and then you're not getting some of the side effects in that particular case. Of course, by combining chemo plus amivantamab, we know that there are some side effects, and Dr. Subari will tell us as well in some of the data with the exon 20 insertions patients. We know that we have some cases, particular cases, because of the EGFR inhibition, the MET inhibition as well, as we mentioned, chemo, and so on. And of course, you're getting some venous thrombosis events, as we have mentioned. Remember here, maybe you expect to have 5% of the patients with chemotherapy having some thrombotic events. You're adding amivantamab, you're getting to 10%, you're getting the triple combination, 20% of your patients will get some thrombosis. So that is important to prevent that. And remember that you have to do some personalized management for those patients. The good thing is that we have now some data already from trials trying to ameliorate the side effects by using subcutaneous formulation. We have mentioned the Paloma-2 study showing that, or suggesting you're reducing some of the side effects, such as, for example, the case for the infusion reaction. Here in this randomized study, giving us monotherapy in combination with lazertinib for those patients that had progressed to OSI and platinum-based chemotherapy. You see here that there is the trial met the endpoints. The endpoint, the primary endpoint, was pharmacokinetic. You're having similar TRO levels at the end of cycle 1. You're having similar AUC as compared to the IV formulation. So from the PK point of view, you're having similar side effects. In terms of efficacy, similar response rate, 30%, a bit more in each of the cases, subcutaneous versus a IV, so similar result. For whatever reason, it looks like duration of response, PFS, even OS, in this study has been improved. There is any reason for that? To be honest, I don't know. Is that really true? The number of patients included in this trial is enough? Well, I wouldn't say it's clearly better. I would say at least it's not at all inferior. And the good thing is that you really dramatically reduce the number of patients with infusion reaction from 2/3 of the patients to only 13%, 66 versus 13%, and you dramatically reduce the number of each individual symptoms associated to infusion reaction. Importantly as well, you're decreasing by 1/3 the number of thrombotic events. 15% versus 9%, and that is true in those patients that are receiving anticoagulation versus those that are not receiving. Remember, as a result of the initial Mariposa trial, for the combination of AMI plus lazertinib, you have to include just patients for treatment with anticoagulation for 4 months, the initial 4 months. So receiving or not anticoagulation, you see that the patients are actually decreasing the number of events. And you ask the patients, they prefer the subcutaneous formulation for most of the cases. And of course, the data we have today in terms of CNS disease, not only for brain metastasis, also for leptomeningeal disease in patients with progressive disease, looks like the the amivantamab plus lazertinib combination is active. Some 30% of the patients are responding in terms of the 34 to 40% brain metastasis, about 23% on those patients with a leptomeningeal disease. So altogether reinforce the activity in the brain for those patients. So the question is there any other treatment I can suggest to my patient as a third line or a further line? And I'd just like to mention a couple of things. ADCs, anti-HER2, anti-HER3 agent, HER10, with topo-1 deruxtecan payload. You see here responses in about 30% of the patients, and most of the patients seems to benefit with these agents, regardless the type of mechanisms of resistance. So that is a reasonable alternative to it. There is another bispecific ADC against EGFR and HER3 with a topo-1 payload as well, responses in some more than 60% of the patients with EGFR mutation in the initial phase 1 trial. I think this agent is in development and it makes all the sense. You're using TROP2 ADCs such as datoderuxtecan, similar, you see responses in some 40% of the patients, more than that in patients that have received at least 2 prior lines of therapy. So altogether, there are a number of other opportunities that are more or less coming. I just put in here some data you have to see during this trial. You like to have a more comprehensive view of the case. And I just handled the data to our chairwoman.
Thank you so much. Thanks for taking us through all that complex and exciting data. So we're going to get the panel just to tell us a bit about what you do second line. Josh, are you using chemo-AMI? What are you doing for your patients that fail osimertinib?
I'm profiling patients at the second line setting. So I'm rebiopsying, I'm doing liquid biopsy first, if non-diagnostic, falling back on tissue. And really depending on the resistance mechanism, it opens up a lot of options. Resistance mechanism agnostic, I think amivantamab and chemotherapy is the standard of care in the second line setting. I think we need to build upon that as well, and there are many other ADCs coming. Curious, Dr. Paz-Ares, what are you doing?
So, I think, as you said, chemo plus AMI is somehow the standard of care based on the robustness of the data. I haven't got, in my particular country, as yet, the drug available due to, let's say, approval issues, so hopefully will come. So I think that would be the best opportunity. If not, I tend to do, there are some other things that you have to look at, maybe more sequential, chemo, and then see what happened with these ADCs. I think there are some data as well that are looking good with some of the novel anti-PD-1 plus BFN inhibitors. We have to see how those harmony data are maturing as well. That could be maybe an alternative into the future if the data consolidate. And for the time being, I would say after progression, maybe I would say chemo plus AMI, if not sequential treatment, chemo, then AMI, or some of the ADCs.
Great, thank you. So we do have some questions here. I want to thank everybody for sending these in. There was a question about the anticoagulation with the amivantamab and lazertinib combination, and what do you recommend? Josh, shall we go to you?
Yeah, so we know that 3 or 4-fold almost higher rates of DVT, PE with utilization of amivantamab and lazertinib. You've shown in your study, Paloma 3, that if you prophylactically use anticoagulation, different types of therapeutics, Eliquis, for example, apixaban, other agents that you can use locally in your settings, reduce the risk significantly of developing these AEs. We know that EGFR inhibitors in general have a higher risk of DVT-PE, so I'm prophylaxing all patients when I use amivantamab up front, particularly amivantamab in combination with lazertinib.
Thanks. Yeah, in the study, we did use prophylactic doses, and for the most part, patients received DOACs for the first 4 months. Yeah. What other prophylaxis? What do you do about skin toxicity? Are you folks doing anything routinely in the clinic?
Yeah. So for the skin toxicity, we ask our patients to start for some 2 to 3 months with antibiotics from day one. even if you start 1 or 2 weeks earlier than the TKIs, AMABI is a good opportunity. Second, moisturizing creams, that is particularly relevant, including on the nails and things like that. Topical steroids, particularly scalp lotions and places, face and trunk, and also in the nails, beds, and so on. I tend to do chlorhexidine or betadine, let's say, washes in the nails. That is helping. If you're starting to have toxicities, you're managing that, and tend to do early consultation with grade 2s to my dermatologist. Just in case, for example, I always start oral antibiotics for grade 2 paronychia, for example, and early intervention like cryotherapy and so on is also important, particularly grade 3. If I'm having grade 3s, remember to maybe dose reduce in your patients, particularly if these grade 3 are not responding in a week or so, or if it's the second grade 3 event you're having in your patients.
Thank you. And when Nicolas Girard talks about toxicity with this combination, he always says he's much more intense. So if your patient has grade 1, he manages it as though they were grade 2 or grade 3. Similarly, if they have grade 2, he treats them as though they had grade 3 toxicity. So that sort of getting ahead of the toxicity, I think, really helps. And of course, that multidisciplinary team. So we've got some questions about subcutaneous amivantamab. Can you start with IV and switch to subQ later? So my understanding is that the requests for approval have been submitted, so we don't have subcutaneous yet, but I suspect when we do, there'll be some wholesale switching when it's available. And when you're picking treatment, let's say somebody relapses during adjuvant osimertinib or stage 3 consolidation or first line, does anything change? Are there some things that say to you, okay, this patient shouldn't have ami-chemo, or this patient should just have chemo, or the combination?
Yeah, I want to know when they progress and sites of progression. So if you're progressing on osimertinib, I would treat that as a patient who progressed in the first-line metastatic setting. They're likely going to have the same resistance mechanism, C797S, MET. But if they progress after stopping therapy, right, year 3.5 or 4, I would treat that patient somewhat differently. So it really depends on progression pattern post-therapy.
Yeah, I think it's important. I mean, for most of the cases, even early stage, EGFR-mutant disease is a systemically widespread disease. So that is the reason I fully agree with this approach. So I tend to do at the time of progression genotyping to be sure what are we dealing with. But the timing between last treatment to the progression is determinant to the way I treat my patients.
Great, thanks. And what do you do when the combinations first line fail? Like, let's say you have your patient on osimertinib and chemotherapy. We know that the resistance mechanisms so far are similar, but do you treat them with amivantamab and chemotherapy, or do you move to docetaxel? And same with amivantamab and lazertinib. What do you do with those patients, given what we currently have second line?
Yeah, it's another great question. We don't have great data here. The issue, again, for patients is if I have a patient who started OSI chemo and they got 4 cycles of carboplatin pemetrexed and then went on to maintenance pemetrexed and OSI and got out 9 months, and then we stop and they progress at 20 months, that's a patient who I would give ami-chemo to again, especially if they can tolerate it. But if a patient progresses within the first 9 months of being on pemetrexed, I'm not sure there's great rationale to continue the chemotherapy there. I might use amivantamab single agent or a clinical trial or another agent depending on the resistance mechanism.
And what about in Spain?
Well, very much. I mean, it's a bit empirical. We do that. We tend to use the time elapsing since last Pimetrexed or whatever to really guide our next treatment.
Sounds great. And I promise we'll get to more of these questions at the end, but I think what we'll do is we're going to move on to the next case. Thank you so much, Dr. Paz-Ares. So this is a different lady. She seems almost exactly the same, doesn't she? She's 63. She presents with a malignant pleural effusion and bilateral pulmonary nodules, good performance status. But this time, it's not an L858R mutation. It's an exon 20 insertion, as you can see there in the second line, along with a number of other co-alterations and a number of variants of uncertain significance. So this patient comes to your clinic to discuss treatment options, and what would you do? So with that, we're going to turn it over to you, Dr.
Thank you,
Spivey.
Dr. Leo. So we discussed the different, EGFR mutations. We talked about common mutations, historically called activating mutations, exon 19 del, L858R. These occur in 70% of patients. We also had a question about PAC mutations or atypical mutations. We're going to focus now on the most rare subtype. These are the EGFR exon 20, generally insertion mutations, and this probably makes up 5 to 10% of all EGFR mutations, but as low as 1 to 2% of your non-small cell lung cancer population. So it's important to test broad panel. We heard from Dr. Leo that PCR-based assays might miss 50% of the EGFR exon 20 insertions. So really, NGS is what's critical here. So what are the approved regimens in the frontline setting? So this is the Papillon study presented 1 year ago at ESMO now. This is a randomized phase 3 trial of amivantamab plus chemotherapy versus chemotherapy alone. Over 300 patients randomized 1-to-1, and again, this is frontline setting. Primary endpoint here being progression-free survival and overall survival. And here you can see the data that led to the FDA approval in March of 2024 here, 11.4-month median progression-free survival with amivantamab and chemo versus only 6.7 months for chemo alone. So a near doubling in progression-free survival. But what's equally as important is the response rate. You see very high response rates, over 70% with this combination versus chemotherapy in that 40% range. It's important that at this conference at WCLC, we'll see an update for some of the subsets, particularly the high-risk subsets by my colleague, Dr. Goldman, looking at P53 co-mutation, looking specifically at site of insertion of the exon 20 mutation, as well as ctDNA clearance. And not to jump the gun and not to give you the results, but regardless of the high-risk subgroup, or irregardless of whether a patient had a high-risk mutation, patients responded better to amivantamab and chemotherapy compared to chemotherapy alone. So I advise you, if you're available, to go and listen to that presentation. So amivantamab and chemotherapy is the standard of care in the frontline setting, and we'll talk about some of the emerging areas. What about the second line setting? So we know in the second line setting, we presented at World Conference Lung Cancer in 2021, cohort D of the Chrysalis trial, which is looking at single agent amivantamab in patients who had progression on frontline chemotherapy. And what was really exciting at that time was that we finally saw a respective response rate. 40% response rate. To put this into historical context, we were never achieving response rates above 20 or 30% for our EGFR exon 20 patients at that time, particularly with first, second, and third generation EGFR TKI. Median duration of response was 11.1 months, and the progression-free survival 8.3 months. Also exciting, we saw broad activity regardless of the site of the insertion mutation, whether it be the helical region, the near loop, or the far loop. Response rates were high. What were the toxicities? We heard from Dr. Paz-Ares already, infusion-related reactions, about 2/3 of patients, as well as the dermatologic toxicities. This is updated data that was presented about 2 years ago now, looking at long-term outcomes in the second line setting. 2-year progression-free survival, median 13.7%. So we still need to do better for our patients in this setting. And when we look at overall survival, median overall survival, 23 months. Again, numbers we have never seen in the exon 20 space, but still at 2 years, only about half of people are alive. So we do need to build upon this data for our patients. So what agents are coming in the second and third line setting? We have multiple novel exon 20 inhibitors. Furmonertinib, sunvozertinib, and zipalertinib are sort of the newer old generation inhibitors, but we have even newer agents now, looking at ORIC-114, Bayer-292, that may have superior CNS penetration in this hard-to-treat patient population. So when we have successful therapies, what do? We move them into the frontline setting. So these are 3 ongoing phase 3 trials in the front line of zipalertinib plus chemotherapy versus chemo. We have an ongoing study of sunvozertinib, And we also have an ongoing study of furmonertinib versus chemotherapy. And we look forward to seeing some of this data emerge just early on, response rates from some of the other early studies looking at these agents in the front line achieve response rates over 80%. So it's a quite exciting time for patients with exon 20 insertion mutant non-small cell lung cancer. I want to focus also on some failures because we can't only celebrate the successes. Mobocertinib was a second type generation EGFR TKI, both a HER2 and EGFR exon 20 inhibitor, initially approved in the second line with about a 28% response rate. Unfortunately, the randomized phase 3 trial was negative versus chemo, hazard ratio of 0.98. So despite many progressing and promising future opportunities, we've also seen many agents not proceed for our patients here. So if you have an opportunity and you meet a patient with an exon 20 insertion, please consider enrolling them on a clinical trial. With that, I'll turn it back to the chairwoman.
Terrific. Thank you so much for that great overview. So how do you choose, Josh? How do you decide who should get what? Should everybody get AMI chemo first? Do you ever do chemo or chemo IO first and save the AMI for later? What do you do in your practice?
Yeah, I'm a major proponent of not saving any medicine for later because you never know if your patient is going to get to that second line setting. I was taught, and I teach my fellows and my residents, use your best therapy up front. And currently our best therapy up front is amivantamab and chemotherapy. I hope in the future, and hopefully in the near future, we have better therapeutic options for our patients that are more targeted. But I think right now I'm using amivantamab and chemo. If I have an option for a study, I'd prefer to enroll on a clinical trial.
Great. And what about in Spain? What are you folks doing?
I'm really also a follower of this philosophy. First treatment, best treatment first, second best second, third best third. And so the best treatment as today, if the patient is a good candidate, is an adequate candidate, is chemo plus amivantamab. So that's the good thing is that we have some 3 or 4 new opportunities there, and it would be very nice to have a bit more data. There are some phase 3 already ongoing, but the data are really looking pretty good. I mean, there are some toxicities somehow, but some of those agents would be nice. It would be very important to see into the future how cross-resistant those agents are as compared to chemo plus amivantamab, see how is the efficacy. We have some at least anecdotal data suggesting that those agents may work after chemo plus ami, so that is going to be important as well.
Yeah, no, I think that there's a lot of interest in sequencing and some of these new drugs that are oral. And I think with subcutaneous amivantamab, as you showed in Paloma 2, you can combine these, you can see decreased IRRs. Now we just have to fix the skin. But that's terrific. So there are a lot of questions from the audience about brain metastases. Why does FLAURA2 work? Chemotherapy is not supposed to go into the brain. AMI-LAZ, you showed all that nice intracranial PFS data. AMI's not supposed to get into the brain as monotherapy. It really wasn't clear that there was activity as a single agent. Why do these work in brain? And also, where does radiotherapy fit in all this? Should we be doing it first? Should we just be doing radiotherapy in OC or using these combinations? There are 12 questions in there. I'll let you, Luis, you go ahead.
Okay, so in terms of starting with the radiotherapy, I tend to use radiotherapy not up front. I tend to use particularly stereotactic radiation. Those patients are going to live quite a long time, very often, so it's very important to skip from radiotherapy as much as you can in terms of field and time, because side effects are coming with time, so it is important to delay that as you can. So I tend to start with systemic treatment. And that is why we have to fully understand, I don't think we haven't got yet why chemo or amivantamab are having such an effect on those patients. That could be particularly relevant because it's not only important that our patients are living, it's very important that they are living as in the better condition. It's not the same living with controlled brain metastasis as without control brain metastases. The things you can do are not quite the same. So I think we have to kind of give very important thing. I don't have a clear answer about why chemotherapy is helping here. For sure, it's entered into CNS because of the disrupted blood-brain barrier. We know that with very sensitive diseases, that you cure them with platinum-based chemotherapy, germ cell tumors, small cell lung cancer. We know that we are getting fantastic responses there. And we have the same data with some of other immunotherapies. What is, for example, for amivantamab, the main effect is due to the immune type of mechanism of action, or is the direct mechanism of action? I would suggest in that case the immune is more having to do as compared to the direct inhibition, because I don't think a lot of this agent is going to get into the brain. But what is more important is the data, and the data suggests those two combinations are beneficial, and I will use them in my patients.
Great. And anything to add, Josh?
I would agree. I think we don't have a great mechanism of why these action drugs are effective. One thing to think about is they may be effective, extracranially in preventing intracranial metastasis as well. To the point you made about avoiding radiation up front, if you have a CNS penetrant drug, really there's no role for things like whole brain. But stereotactic radiosurgery or even resection in a young, fit patient actually can do very well.
And there's a rat-onk in the room, clearly, who's sending in questions. Good for you. So we're going to ask your question. And it's, you got all these great new expensive toxic drugs, but why don't you just use radiotherapy, especially in the setting of oligometastatic disease? And so are you guys using more radiotherapy in your practice? Do you make an active choice between sort of drug intensification versus multimodal therapy?
So I tend to use radiotherapy, particularly for those patients that are having oligo progression, and that's helped you very often to keep systemic treatment for a while. So particularly, if my patient is tolerating very well, let's say a TKI is having, like a monotopic or bitopic progression, easy to irradiate, I'll do that, and then see what happens next.
Yeah, Josh, the same?
Huge fan as well. Just very hard to define what is oligoprogression.
Great, and we are at the end, but doctor, if you have a very quick question that we can answer in 30 seconds or less.
I think the thing is your opinion about the anticoagulation, because we have near the 60% of the patients have a thromboembolic event in the first four months. So the recommendation is of the time, because near the half of the patients have a thromboembolic event after that. So, and we're just stopping the anticoagulation. So what do you think of stopping anticoagulation when you give lazertinib and amivantamab combined?
Okay, so I think what is being seen is that most of the events, are happening on that time frame. And so what are you seeing is that some 37% of the patients are having that without any anticoagulation. By using some subcutaneous formulation, it looks like you're preventing some to happen, but still the number is relevant. I would say the recommendation is quite strong to use in all patients for at least 4 months anticoagulation, routine anticoagulation. The second question would be, if your patient is not having amivantamab, should we use always anticoagulation? Well, in many patients, only using chemo and advanced adenocarcinoma, more than 10% of the patients are having thrombotic events.
So with that, I'm afraid our buzzer has gone. I really want to thank our amazing speakers. I want to thank the PeerView and J&J team and our fantastic audience. And we wish you an amazing WCLC. Thank you so much.
Thank you for listening. Remember to download the slides and practice aids and complete the post-test for instant credit. This activity is certified by PVI, PeerView Institute for Medical Education, and is accredited by the European Board for Accreditation of Continuing Education for Health Professionals. This activity is supported by an educational grant from Janssen Biotech Incorporated, administered by Janssen Scientific Affairs, LLC, which are both Johnson & Johnson companies. To access all materials for this activity, visit peerview.com/EQU860.